Please, Fortunato.
Thank you very much, Filippo. I thank you for this kind invitation to be part of the first day, the day that is devoted to targeted molecules for targeted therapy. So the first session will be divided in two presentations, and each presenter will deal with two important targets for lung cancer. It is really a pleasure for me to introduce Professor Tony Mock. Actually, there is no need for introduction for Tony because he is very well known worldwide for his extraordinary expertise and role in lung cancer research. And he will deal with the two of the most known and relevant targets in this disease that are the epidermal growth factor receptor and the ALK gene rearrangements. Please, Tony. Tony, we don't hear you. Maybe you have to open the audio.
Buongiorno. So it's great pleasure of mine to be able to speak a word of Italian again. You know, I really look forward to coming back to Italy in the near future. And thank you for Filippo and Antonio for actually the kind invitation. So I'm going to spend next 20 minutes to talk about two of my favorite topics. So first of all, this is actually my disclosure. More specifically, I'm on the board director of these three companies, AstraZeneca, HUTCHMED, and also Sanofi. So I want to do some calculation. I got 20 minutes, which is about 1200 seconds. I got 5 TKI, 6 ALK TKI. So I have to only have about 109 seconds per TKI. So it's impossible. So I'm not going to talk too much about the drug, but rather I'm just going to give you a bit of a landscape and then going to focus on what may be new and exciting in these two areas. So let's first focus on the landscape. Now, this is actually the summary that I like to see that any one of this treatment can be used as a first line. The first generation drug, second generation drug, osimertinib, combination with chemo, combination with anti-angiogenesis. All this have been studied in a randomized study or being studied in a randomized study, and there are some potential benefit. But then, how are we going to choose? So the question is that how we choose is based on the data, but on the data is actually on the question of the sequence, because every drug got its own benefit. But let me just try to analyze the optimal sequence if we want to try to achieve the best overall survival for you. For the first line TKI, and then we've got treatment beyond progression, and then we got multiple subsequent line treatment and eventual supportive care until death. But then in the clinical trial, we only measure the progression-free survival number 1. And then the progression-free survival number 2, most of the time is actually by medical record only. And then the overall survival is the real number because there's a date when the patient died. But if you look at the whole experiment, the first part is controlled, the subsequent is uncontrolled because once you stop, you know, at the time of progression, the doctor will do the different thing according to their healthcare system, own wishes, and the patient's wishes. So in a sense, when we try to compare one study like the FOREST study or osimertinib versus the second-gen drug, we may show a progression-free survival. We may also show overall survival, but then we have no way to assure that it's an equal in the subsequent therapy. So when you choose a therapy, although it's kind of important to look at all this data, but we have to keep in our mind that there are a lot of uncontrolled factors that influence the outcome. So that is on the EGFR. Now, what may be new and exciting? Well, FORWARD-2 is on the way. Now, FORWARD-2 is the question that I just mentioned about osimertinib is already the standard. Can we actually combine with chemotherapy to make things better? We have done that with the first generation drug, and now we're doing that with the third generation drug. But I want to give you a little bit insight how likely it may be better. So, you know, in Japan, it just Dr. Takana just published in EJC this year, looking at a second-line situation in the T7-ICM positive lung cancer patient. Then they just randomized osimertinib versus osimertinib plus chemotherapy. So that is the data already published in the second-line situation. But you can see that both the progression-free survival and also the overall survival and the response rate are actually very much similar. So based on this, there's actually no significant difference in this regard. Now, this is one. But then there's another concept that's coming up is actually using the combination of amivantamab with dasatinib. Now, I will talk about that a little bit on the second-line situation later on. But in the first-line situation, this is the Mariposa study, the three-arm study of dasatinib plus amivantamab versus osimertinib versus dasatinib. So potentially, when this study comes out, which is over 1,000 patients, there will be one other regimen or two other regimens that's available for us to consider. Now, but then the endpoint of this is mostly arm A versus arm B. I don't think dasatinib, which is a third-generation drug producer in Korea, may have a chance of going out of the international space. That may be a little bit limited. Now, moving on a little bit is on the resistance space. Now, for the first-generation TKI, of course, that you have the T7M as the most common resistant. But once you go to second line osimertinib or first line osimertinib, the most common one is C797X, HER2, and MET amplification. And then a good 2/3 of them may still be unknown. So the question is that how do we really can be able to tackle it? So I think there's a lot of work that to be done on this unknown part, because a lot of the time we only use the targeted sequencing, which only had the limitation of a number of the gene. So we may not be able to explore some of the so-called mechanism that is undetermined. Now, as I told you, amivantamab is a bispecific antibody of EGFR and MET. Dasatinib is a third-generation TKI. And then there's an update of this particular study looking into so-called the patient who failed osimertinib and then received this combination. The result reported was about 36% of the response rate, and the median progression-free survival 4.9 months. It's reasonably decent, and toxicity is actually well tolerated. The question is that, who may benefit the most from the situation? Because, in a sense, when you see this kind of a above average but not super well situation, you want to further identify the patient who benefit. So they look into a number of considerations. One is something called the MET or EGFR related mutation, like the C797X, other EGFR mutation, or the MET mutation. But then they also look into the other so-called the non-MET or EGFR mutation, like the PI3K. But they find that the result is about the same. So they cannot really differentiate that. The only thing that may be interesting is the fact that for the patient that have done the performance of IHC that have either EGFR or MET H score to be more than 400. Those are the patients who may benefit. Very small sample size, only 10 patients, but then out of 10 patients, the nine patients responded because of because when they have the EGFR MET score that is over 400. So it is an early indication, but it needs to be validated much further. Now, MET, since we talked about that, we already got two drugs that is targeting MET14 skipping, but can we apply that to the EGFR situation? The best data that I've seen so far is the Titan study. They are trying to identify the patient by MET amplification, defined as either FISH over gene copy over 5, IHC 2 or 3, or NGS with 5 copy number. This is a multi-cohort study. The cohort part B is the actual combination with osimertinib with savolitinib. Part 1 is the patient with prior exposure to first-generation TKI. Part B2 is the first or second-generation TKI, and then T7M negative. Part B3 is actually T7M positive. Now, Part B2 and Part D are actually the same, except that the osimertinib dosage is lower at 300 milligram QD. Now, because of the different exposure, the line of therapy is a bit different, but that probably will not affect the overall outcome too much. The exciting thing is this: for patients who failed osimertinib, MET amplified, if you combine that with savolitinib, the MET inhibitor, you end up response rate of 33%. Quite nice. I mean, for this population, chemotherapy response rate is about 30%. Part B1 is not that exciting in the sense that they are T7M positive. You receive osimertinib after first-generation drug, you expect 30%, 70% anyway. So the MET doesn't seem to add too much to it. But if you had first or second generation and then fail, but T7M negative, and then that circumstances, osimertinib may not work. But in this case here, with the combination of a MET inhibitor, you actually have the response rate of actually about 62 and 65%. And this is actually quite impressive. But then in this study, we're not able to define which are the MET biomarker to be used in this particular study. And this data is actually transformed into a progression-free survival of 9 months and 11. Now, if you compare with the IMPRESS study, when you're T7M negative, you receive chemotherapy, you got a median progression-free survival of about 5 to 6 months. And now you have 9 to 11 months. So the chance of winning is quite high in this amplified population. Another potential is the antibody drug conjugate. You know the concept well. The new development is the fact that they have a better linker and that they have the higher disease load, about 1 monoclonal antibody with about 8 cytotoxic drug molecule. And the one that is a reference for EGFR is the U3-1402. And this is the one that is anti-HER3. Most of the patients that have EGFR mutation, they actually have HER3 amplification or alpha expression. So this is a potential target. Pasiani, actually report this phase 1-2 study, a dose escalation study, and they actually reported a response rate about 39% and a median progression-free about 8.2 months. Now, this is actually encouraging. So in a way is that, again, similar to amivantamab, is a really above average response rate, but we want to know who benefit. So one thing to predict it is the fact that if the patient actually had clearance of the cfDNA, they actually will have a median progression-free survival 8.2. If they did not clear, they got median progression of 4.4. And then that is actually corresponding to the response rate. And then there are some patients with the brain met responding as well. For biomarker selection, the H3 score actually is not helpful because they kind of scatter all over the place. And they also looked at the genomic profile, then they were not able to identify any specific molecular marker that determined the response rate. So encouraging, but we still got a lot of work to do to decide what is the best approach in utilization of this ADC. Now, the way I see it to move forward is that whether you're going to place it post osimertinib, and then chemo naive, randomize the HER3 desotucan versus the platinum chemotherapy, or you can do it after you fail the platinum chemotherapy and compare it to docetaxel. Which is the best approach? I think it remains to be defined. But overall, I think this is one feasible drug that we can utilize it in the EGFR space. Now, of course, the other approach is the immunotherapy. This is IMpower 150. The slide on the right-hand side is the 4-drug, taxol, carbo, bev, and atezo compared to the taxol, carbo, bev, and their improvement in both the progression-free survival and overall survival. But then the one on the right-hand side that you see is that actually just only with the atezolizumab with chemo compared with bevacizumab with chemo, and there's no survival benefit in either progression-free or overall survival, suggesting that there may be some magic in combining the anti-angiogenesis and the anti-PD-L1 therapy. But how to move this forward? Well, this is a very small retrospective analysis, about 30-some patients in HR. So we need to actually know more. So this is one study from France that looked into this combination of 4-drug combination using pemetrexed versus the pemetrexed, carbo, and atezolizumab. Study is ongoing. Another important study is actually the one that is actually from Japan, is the Apple study. Again, it's almost like exact design. And then there is also the China study, as phase 3 study called IMpower 151. In this particular study, is pemetrexed or taxol plus bevacizumab versus the 4-drug combination. Now, the special thing is that they do allow EGFR mutation ALK up to a certain percentage, up to approximately 50% of the patient may have this mutation. So we will likely end up with more data in this regard based on this based on this IMpower 151. Now, the other study are the one that is actually on the chemo failure. TKI failure, chemo plus IO versus IO. Checkmate 722, T7M negative patient, chemo plus Nivo, Nivo EP versus chemo. But after a while, we actually drop off the EP Nivo arm. So now it's the chemo Nivo versus chemo. The study had completed the enrollment, the data waiting to be so-called mature. Same thing, Keynote 789 is also chemo plus pembo versus chemo, and that is also for T7M negative patient or T7M positive patient failing osimertinib. Again, this is complete accrual, waiting to be reviewed for the data. So I think there's a good chance that one of this PD-L1 or in one of this formula will fall into the EGFR TKI failure, the population, and then we just have to wait and see. Now, that is the landscape, and but now that we probably have to move into the ALK. Now, in the ALK situation, again, I give you this table. We have 6 choices: crizotinib, ceritinib, anatinib, brigatinib, and ensartinib, lorlatinib. So out of all this, I think one important message. This is data that Solange, Peter, and I reported in Annual Oncology just last year. Look at the 5-year survival rate, 62.5%. 2/3 of the patient with stage 4 lung cancer still alive. I think this is probably one of the best records I ever seen. Our good old days, you know, when Filippo was younger, then the 5-year survival rate of stage 4 lung cancer was only less than 10%. So now we make it up to about 62.5 in this particular subgroup. Now, this year in the ASCO, in the CROWN data, they also look into the potential of use molecular marker, looking at the VAF, and then they find that there is a drop at the week 4, but then a certain percent of patients just progress again. So there is an interesting dynamic reported by Dr. Ross Xu from Singapore in the ASCO this year. So potentially the dynamic changes of the ALK can be measured together with the treatment plan. And also that there is the data from this one is that if they were able to clearance of those information of the plasma VAF, they got better survival. And from ALK study, we got the same phenomenon. Patients who got clearance from anatinib, you got the best survival. And then patients who did not clear off the plasma DNA, they got the worst survival. So I think all this data together has suggested that potentially we can apply plasma monitoring as an indication of survival. But then there's still many questions to be answered. So should we really measure plasma after treatment? And then once we have that, should we change the treatment if it's positive? If change the treatment, what can be the treatment? Are we going to identify resistant ALK and change our drug accordingly, even though there's no radiological progression? So I think a lot of clinical work needs to be done in this regard before we can consider on it. And then, you know, the other one is to look into the what may happen in the post-anatomy space. Now, this is actually a work that was reported in CCR in 2019, very comprehensive. Now, I want to show you, you know, this regard, the fact that the most common resistant is the G1202R, L1171, and then L1196M. Those are the most common one after you fail anatinib, the second-line drug. So the question is that how best to approach it. Now, in the same time, if you look at the post-lorlatinib, you again see the common thing is that there are actually patients have 2 or more ALK mutation. So I think the new knowledge is the fact that the more potent drug you give to the patient, although they may have a very long progression-free survival, but once they have resistance, it can be more complex and more difficult to treat. The gene may be more difficult to treat, and also the complexity of more than one mutation that make it difficult. But if you look at it again, L1196 come up, G1202R come up, and then I1171 come up. So these 3 stubborn mutation are the one that may occur after your 2nd or 3rd generation TKI, anatinib or lorlatinib. So I think the new thing is to be able to target the L1196M and the G1202R. So one of the new drugs that I want to introduce is TPX0131. The drug is actually, the molecular shape is different from the either 2nd or 3rd generation. So you may call it the 4th generation drug. That this one, they come in the pocket, as you can see that the IC50 is actually the most potent compared to the 2nd and 3rd generation drug. And in the so-called animal study, you were able to see significant inhibition of the cell line that is actually infected with the so-called resistant gene. So based on this, I think that there is one study that's going to be happening now. It's called the FORGE-1 trial. It just started about a couple months ago, and that will be on the patient who failed the second generation TKI, have to fail the 2-line of the ALK. So look out for this new development, TBX0131. And hopefully in a few years, we may be able to find the answer for that. Now, last but not the least, I have to say that we have moved into the adjuvant space. In the ADAURA, there's no doubt that there is a significant difference in the so-called progression-free survival. Disease-free survival has a ratio of 0.17. And then also that is after 3 years of adjuvant osimertinib. And whether stage 1B, you have a ratio of 0.5, stage 2, 0.17, stage 3, 0.12. Definitely better in that regard. And this is not only a EGFR. Anatinib is moving in as well. There's a study called the ALINA study, 255 patients randomized to adjuvant anatinib versus chemotherapy. And the study is still recruiting. It's not so easy to do this study. So in summary, I think that we really have moved quite a bit forward with the EGFR mutation. There are multiple options right now. And now we may consider a lot of new toys for the resistant, including bispecific antibody, MEK inhibitor, and antibody drug conjugate. For the ALK, again, we got multiple lines of treatment. I think right now that is actually consideration to monitor the response with the plasma DNA. And now we also had the promises of potential 4th generation drug that target the L1196M and G1202R, and also potentially that we'll look into the adjuvant space with the adjuvant ALK inhibitor. So under the note, I once again thank you for their invitation to be able to speak from you from a distance. But certainly it has been very joyful to be able to be part of the group again. Now, just in case you want to know, one last slide is that why Pasiyani and I are actually so interested in target therapy. The answer is that we practice a lot. And this is a picture of how we practiced target therapy when we were in Japan. So thank you so much for your time. And again, thank you for the invitation.
Thank you, Tony, for this very nice and comprehensive review and presentation. I know that you are around midnight in your hometown right now. So therefore, I would like to do a few questions for you just to free you after the presentation. And the first question for me will be, what are for you the real unmet needs for an EGFR mutant lung cancer or for an ALK translocated lung cancer today? What is the real important research that needs to be done?
Excellent question. Now, there's two aspects. One aspect is that if we have been working on EGFR mutation for now over 15 years, there are patients who survive for 10 years with the 1st generation TKI. So I don't think EGFR mutation is a one disease. There are actually patients who do really well and well behaving, and there are patients who progress in a few months. So I think we still need to know who are the good behavior patients, who are the not so good behavior patients that we need to do more. So I think differentiation with the good prognostic group and the not so good prognostic group that I think we still need some research on. Indeed, the answer may still be there because we actually have patients in clinical trial who survive for multiple years. And we can do actually a lot more genomic study to understand why. So I think that is one area of research that we want to do. Another area of research is actually on the reason why EGFR mutation occur more in Asian than the Caucasian population. There must be a genetic link because otherwise that we would not see such a strong ethnic domination of this particular mutation. Up to this moment, we still don't understand it. Now, it's not so much just on treatment alone, but rather on prevention, but rather on how do we actually understand the genomic predisposition to cancer formation. So I think that is another still very basic research we need to do. Last but not the least, I think at this moment, the immunotherapy still have a really marginal impact on the EGFR mutation positive lung cancer patient. I think we still have to find different ways. The one direction that I'm thinking is the microenvironment. Most of the EGFR mutation actually still have a rather cold, immune cold desert environment. So how do we transform that? What are the drugs that can actually encourage the T cell to penetrate to this cancer? I think so that the application of the immunotherapy, not just by biomarker, but by tackling the microenvironment, I think that would be very interesting. So those are the three areas that I think that we still are very in demand of the future research.
Thank you very much, Tony. Thank you again, and goodbye. Thank you.
Thank you. Bye-bye. Bye-bye, Steve. Bye-bye.
And now, I don't know, I should say good morning, because I am introducing Stephen Liu for the next presentation. And Stephen is the director for thoracic oncology at Georgetown University in Washington, D.C. And he will discuss with us lung cancers in which ROS1 or BRAF genes are the drivers. Please, Stephen.
Well, thank you very much for the invitation. I'll echo Tony's thoughts that I certainly wish we were all together in person, but regardless, virtual or in person, this still is my favorite collection. Great to hear from Tony and Solange, and nice to have the opportunity to bring us up to date with ROS1 and BRAF. These are uncommon, rare subtypes of lung cancer, but equally important because they do have unique management. We're familiar with ROS1 as a receptor tyrosine kinase. This is an oncogene. It has transforming potential, and we see chromosomal rearrangements throughout cancer. While we know them best in non-small cell lung cancer, they do occur in other tumors. I have a patient with a thyroid cancer, for example, who's been on targeted therapy for about 5 years. Overall, the incidence is around 1% to 2% in non-small cell lung cancer, and this is, as we know, a validated therapeutic target in non-small cell lung cancer. It is critical to find this when present. It will alter management radically. Finding it can be a bit of a challenge. Detection methods do vary. Initially, we were all using break-apart FISH, which does have some problems with sensitivity. Now we're moving more towards sequencing, be it DNA or RNA, liquid or tissue. Immunohistochemistry has a variable performance and not bad as a screening tool, but certainly does require confirmation. Challenge really is in false negatives. And this is a setting where RNA may be advantageous. While I acknowledge that it does add cost and not all sites have access to RNA sequencing, this work done by our colleagues at Memorial Sloan Kettering show a potential advantage. These are patients who had DNA-based next-gen sequencing for advanced non-small cell lung cancer, did not have a driver identified. And so that was 254 patients. They then subjected their samples to RNA sequencing, and in 13%, they identified an actionable alteration. The most frequent was ROS1. If we look here, these weren't esoteric alterations that would be difficult to find atypical variants. We see EML4-ALK, and we see multiple cases of CD74 ROS1. If we are only using DNA-based next-gen sequencing, I promise you, we are missing some ROS1 fusions, and we are treating those patients inappropriately. The reason why is because intron 31 is poorly covered. It's very long. And like NRG1, when you have long intronic regions, you simply lack the coverage depth with DNA-based NGS. RNA really is the future. If we want the best NGS, if we want to identify every driver that's out there, I do feel that dual extraction and running DNA and RNA in sequence or parallel is really appropriate. One of the challenges with ROS1 is there are many fusion partners and variants. The significance of these is unclear. Here's a table from Ignatius Zhu showing 22 variants. There have been more since. Will the variants impact prognosis or sensitivity to TKI? Will we see what we saw in ALK, where variant 3 in ALK really predicts a poorer outcome? Will we see the same thing with ROS1? Will it dictate biologic behavior and CNS tropism? We don't know. This will be more challenging to detect because ROS1 is more rare than ALK, but this is really a setting where global collaboration and pooling all of our experience, I think, will yield the answer. We do know that ROS1 has some differences in behavior, and multiple studies have shown that ROS1 fusion positive lung cancer does have a higher predisposition to venous thrombotic events. Not entirely sure why. Here's work from Dr. Chiari in the phase 2 Metro study showing a whopping 41% having a VTE. A retrospective analysis by Terry Ng and Ross Camage showed the odds ratio at 2.44. Not really meant to guide therapy, but really meant to remind us to have a high index of suspicion for venous thrombotic events in ROS1 fusion lung cancer. A little more controversial is the role is the incidence of brain metastases. This is not consistently reported in early trials. Back in our early stages of investigation, we didn't routinely do brain MRIs on regular bases. Our prospective trials, though, do note brain mets anywhere from 20 to 60% of non-small cell lung cancer with ROS1 fusions. And MGH comparison showed that ROS1 brain metastases were common, not as common as in ALK. However, a subsequent study done by Bob Doble and Tejas Patil at Colorado really showed equivalent CNS tropism for ROS1 and ALK brain mets in a third of patients at diagnosis, and is the first site of progression in 47% of patients. When we have someone with a ROS1 fusion positive lung cancer, an MRI with and without contrast really is critical to the proper staging given the high tropism there. How do we treat ROS1 fusion lung cancer? Well, a nice coincidence is that the kinase domain of ROS1 shares significant homology over 3/4 with ALK. And as a result, many ALK inhibitors are ROS1 inhibitors. But to any trainees that are tuned in, most important point is not all ALK inhibitors are ROS1 inhibitors. Alectinib is a wonderful ALK inhibitor. It is a lousy ROS1 inhibitor. And so these are different TKIs. We can't use these interchangeably, but crizotinib is active in both. This is one of our most versatile early drugs, a multi-kinase inhibitor with activity at MET and FDA approvals in ROS1 and ALK. We go back to that very impactful phase 1 profile 1001 study. This added a ROS1 cohort in 2009. And looking at crizotinib given twice daily, they enrolled 50 patients over 3 years. Slow enrollment, but remember in 2009, 2010, we weren't doing NGS, certainly not doing RNA-based NGS in as many patients, and it wasn't done routinely at the very start of therapy. What we saw from that Profile 1001 study is that crizotinib is very active with a response rate here of 72%. This is our paradigm for targeted therapy. We look at this waterfall plot and we see the vast majority of patients with response. The official response rate is 72%, but really all but a handful of patients with some reduction. Responses are quick, generally occurring at the first scan in 8 weeks. For patients who have given the drug, symptomatic patients notice improvement often within days. These responses tended to be durable. In that 1001 study, the duration of response was over 2 years, median PFS of 19 months, shown by that Kaplan-Meier on the right. This illustrates how dramatic the responses can be. This is an effective targeted drug. This is a validated target in a specific context of vulnerability. We can really impact the disease when we find a ROS1 fusion. And when we look at real world data, we see some variation. These are data from Fudan University showing response rate equally high, but the PFS not nearly as high as we saw in that Profile 1001 study. It does, however, validate the CNS as a common site of failure in this trial. So when we look overall, the response rate is consistent with crizotinib in this setting, but the PFS has pretty wide variation. And you can cite whatever story illustrates your point. While the response rates tend to be 70 to 80%, we see PFS anywhere from 5.5 months up to 20 months. Now, why so much variation? I think there's a lot of heterogeneity within this disease. One of the points here, if we look at studies from Yilong Wu and Dr. Michel's, we can see that if patients have brain metastases, much shorter PFS, likely due to the poor penetrations of the drug within the brain. A lot of these studies didn't report the breakdown of brain metastases or didn't properly screen patients. And so maybe that's one of the contextual clues as to why we see such variation with PFS. And I think we've seen it in our practice. There are some patients who can remain on an early generation ROS1 TKI for many, many years, and others where these drugs are only initially effective, but resistance breeds very quickly. Crizotinib with clear activity was approved in 2016 for ROS1 fusion positive non-small cell lung cancer. The other drug approved here is entrectinib. Entrectinib is a potent multi-kinase inhibitor with activity at ROS1, TRAC, and ALK, and greater potency in vitro at ROS1 with better IC50s. The main data comes from this integrated analysis of 3 clinical trials, ALKA 372001 and the STAR TREK study, STAR TREK standing for Study Targeting ALK, ROS, and TRAC, very clever name. This was a large trial, 161 patients with a ROS1 fusion lung cancer given entrectinib once daily. And this waterfall plot, again, passes that eyeball test. This is what targeted therapy looks like, where nearly everyone responds, where when you give this drug for ROS1 fusion positive lung cancer, you really are confident in what's going to happen. Here, the response rate, 67%, durable responses at 16 months, PFS here at 16 months, median survival not yet reached, but over 80% of patients alive at a year. We see activity in patients with and without brain metastases with comparable response rates, though the outcomes are slightly worse in those that have CNS involvement. If we look at those with measurable CNS metastases, we see the intracranial response rate at 80%, and median time to response there within a few weeks, intracranial progression-free survival of 8 months. This is a CNS penetrant drug. And when we think of crizotinib in other settings, the most common site of progression is the brain. By introducing a drug rationally designed to have CNS penetration, we are going to improve outcomes overall. And so when we look at these side by side, you can see wide variation. How do we reconcile these? Response rates generally around 70%. In the Star Trek studies way at the bottom with an update in JCO earlier this year, this is the largest study, and you see that PFS is maybe comparable, falls in that range for crizotinib. How would these fare head to head? When we look at these two drugs, they have different toxicity profiles, but the tox profile primarily has to do with NTRK involvement. Entrectinib is likely to have better CNS coverage, but we wouldn't expect them to overcome resistance to each other. And that's important. If someone progresses on crizotinib, I wouldn't expect entrectinib to be effective, and vice versa. Since we're not planning a head-to-head, how do we do cross-trial comparisons? Well, while the tox is different, again, primarily mediated by NTRK, I do think entrectinib has more activity. One of the issues is that Profile 1001 was done many years ago before NGS was done routinely. And I have found in my practice that ROS1 fusion lung cancer really comes in different forms, that there are some that respond quite well to targeted therapy for long periods of time, whereas others are much more aggressive and develop resistance earlier. In Profile 1001, just by the nature of the environment at the time, patients that had that more aggressive type of ROS1 likely were underrepresented in that initial phase 1 study. And I think that can inflate some of those outcomes. If you did do a head-to-head today with entrectinib to crizotinib, I would expect entrectinib to perform better. And so I do think it is a different drug. I do think it's more potent with advantages, but it does have a different tox profile that's important to keep in mind. What do we do at resistance? Lorlatinib is an ALK and ROS1 inhibitor. We heard from Tony, its activity in ALK. Here we see the ROS1 activity, very high response rate, 60%, very durable in the TKI naive. And post-crizotinib, we see a response rate of about 35%. Very durable responses. This really is the drug we have available, though this not part of the FDA label. When we look at real world evidence, it does corroborate these response rates that can be quite durable. This data from Dr. Viola Ju. And when we break down the resistance to both crizotinib and lorlatinib in ROS1 fusion lung cancer, we see the most common point mutation is that G2032R at about a third. But also note that a significant portion, about 2/3 post-crizotinib, develop ROS1 independent mechanisms of resistance. And as we move forward in ROS1, as our drugs get more selective, it's likely we're going to see these other bypass tracks play a larger role in resistance, and we'll need to identify those and really see what we can do to overcome and prevent resistance. This showing that there can be a role for some of the newer agents with good IC50s for some of these resistance mutations, but that G2032R we see is a weak point for lorlatinib and crizotinib and entrectinib, whereas some of these other drugs, such as repotrectinib, have very clear activity. Repotrectinib, or TPX005, is a next generation ROS1 TRK inhibitor. This is one to keep an eye on. This has breakthrough designation for NTRK, but also for ROS1 in both TKI naive and TKI experienced. And this waterfall plot, again, showing very high response rates. In that TKI naive group, a response rate of 91% with very long times on treatment. So repotrectinib really is probably going to be our answer for 2032R, both overcoming it in the experienced subset and preventing it in the primary subset. So this, and again, another drug to watch. We have other drugs on the market as well, but if we do exhaust our TKI, as a reminder, that chemotherapy is an effective modality for ROS1. Here's data from Dr. Chen showing that ROS1 really had the best outcomes out of EGFR and ALK with response rates of 60% just to platinum-based chemotherapy. However, immunotherapy largely ineffective. ROS1 is a tumor where PD-L1 expression is quite high, but in this context, it has a different meaning. And the response rate, 17%, only one person really responding, rapid progression in the vast majority. I would consider this a non-immunotherapy responsive tumor as of now. Important as well is ROS1 can mediate resistance in other settings. We're seeing this where the same tracks are being used by cancer cells over and over again. Here in L858R that develops a ROS1, and when we identify it, we can target it, in this case, a combination of osimertinib plus crizotinib. We're seeing that more and more. So ROS1 is important to detect when it's present. It informs us about the biology, the prognosis. Think about RNA next-gen sequencing to really find this, and start with targeted therapy. Crizotinib and entrectinib are preferred agents. We have other drugs in development, including repotrectinib, but this is a very important one to find. And again, I promise you, we are missing some ROS1s. A little bit easier to find is BRAF. BRAF is present also about 1 to 2%. And unlike a lot of other targets, this is one that can occur in smokers. We can break this down by V600E and non-V600E, and that's more based on therapeutic implications where we have drugs approved for V600E, but you can also classify these based on their functional impact. Class 1 mutations are activating, RAS independent, where the signal is really through monomers, whereas class 2 and 3 are less likely to respond to BRAF inhibition. For some, maybe a role for MEK inhibition, though not yet validated. Here's a characterization from Dr. Dagogo Jack, again, showing that 2-3 is more likely to be genomically more complex with KRAS co-mutations and clinically a more aggressive course with brain metastases, shorter PFS, shorter overall survival. Is the class 2-3 mutations really still are an unmet need. Most of our activity has been in that class 1 V600E mutation. This work largely done by our colleague, Dr. David Blanchard, showing dabrafenib alone has a response rate of about a third, but 12% will develop cutaneous skin cancers. And this is echoing what we see in melanoma. Following their lead, we looked at dual MAP kinase pathway, which showed a lot of preclinical validation and established study in melanoma. Here in lung cancer, we see the same. In previously treated patients, the response rate of 63%, a more impressive waterfall plot, responses around 9 to 10 months, and the toxicity better. So when we look at the combination, not only more effective, but better tolerated. And that's both in the pre-treated setting and in the treatment naive setting shown here. 36 untreated patients, response rate 64%, PFS 11 months. So this combination really is our preferred modality. This was approved by the FDA in 2017. Here are some updated data from ASCO, again, showing that over time, those numbers didn't really change. Response rate in 60 to 70%, duration around 9 to 10 months, with good tolerability. Primarily it's pyrexia, fatigue, nausea, vomiting, but generally I haven't had to dose reduce patients when I've used this combination of drugs. Resistance is as you would expect. The challenge with BRAF and with KRAS is that these are central pathways, and that MAP kinase pathway has a lot of partners, a lot of opportunities to develop resistance. That's exactly what we see with mutations in NRAS and KRAS, PTEN and MEK, all mediating resistance to the upstream BRAF inhibitors. Now, unlike some of these other alterations, though, we can see that BRAF positive non-small cell lung cancer can respond to immunotherapy, the median PD-L1 expression about 50%, but you see that response rate of 24%, pretty similar to tumors without mutations. One wonders if these are really the smokers with BRAF V600E, and if they're biologically different from non-smokers, but that hasn't really been truly validated. That's generally my approach. Again, same as ROS1, we see these same pathways pop up over and over again. This is one of my patients who had an exon 19 deletion, received osimertinib, and developed an acquired BRAF V600E mutation that later would respond to a combination of osimertinib, dabrafenib, and trametinib. So if we keep looking at resistance, we're going to see these same familiar pathways evoked. And if we have the right drugs, we can potentially combine them. It will be hard to do prospective studies in this setting, but if we continue to report our outcomes about tolerability and safety of these combinations, I think we will move the field forward. So take home from BRAF, not all mutations are equal. And oncologists increasingly need to be molecular pathologists. We need to recognize the difference between the V600E and the non-V600E mutations. This is one where targeted therapy is effective, and dabrafenib, trametinib is our preferred initial therapy, but they can also be immunotherapy responsive, perhaps more likely in those with a smoking history. So a lot to cover, exciting fields moving forward. Thank you so much for the invitation, and looking forward to doing things in person again, hopefully soon. This from the last in-person conference in Naples. Thank you so much.
Okay, thanks, Stephen. I hope the next time will be much better. You can come back to Naples in person. I have a quick question for you. You know, BRAF mutants, even V600E, could be very different from disease to disease in the context of the disease. For example, we know that in colorectal cancer is not exactly like in melanoma. What do you think is in lung cancer? Is more similar to melanoma or to colorectal cancer, the context of BRAF mutation?
It's a good question. And I think it has more to do with co-mutations in the environment, but my experience really has been a bit more like melanoma. And this is one instance where I think we're learning a lot from our colleagues there. But disease type does still matter. And we do know that targeting this in colon cancer has been more difficult, maybe because of the EGFR pathway providing a more signaling escape for colon cancer. So my experience has been a bit more like the melanoma experience.
Okay, thank you very much. And I guess you will be involved in the Congress again later, I guess tomorrow. Okay, thank you very much. And I guess now we are at the end of this session. Next session should be chaired by my friend Nicola Normando. So I ask Filippo how to move to Nicola for the next session.